the ICU specialist. Conrad came and showed it, brought the actual ECMO device down and showed us the 3 holes, how you want the upper hole in the supravena cava, the middle one, the reinfusion port in the right atrium, and the lower hole in the IVC. So Tope is going to talk about ECMO, and then I'm going to talk about how I showed it.
Good afternoon, everyone. Dr. Gates has already introduced me. So this afternoon, I'll be discussing the role of radiology in management of ECMO device. Basically, my objectives will include to review the publications on radiological appearance of ECMO, the different types of ECMO circuits that we have, the types and locations of the cannula, which is what we usually assess for the critical care doctors, and also the imaging appearance of complications that may arise from the use of ECMO. I'll also be reviewing the imaging findings in LSU Radiology here. Like he said, so basically it is important for radiologists to familiarize themselves with the type of ECMO cannula that is used in their institution. And this sometimes is constantly changing. So even as they move to another one, we need to familiarize ourselves with the new device that is being used. Before I delve into ECMO, well, my presentation is on ECMO, but I met with Dr. Conrad and I was able to understand the overview of what ECMO is all about. And if you look at this, so this is like an overview. It's not just ECMO alone, but we have other devices. So we have the extracorporeal life support, which includes the ECMO and the ECO, okay? The ECMO, which is extracorporeal membrane oxygenation, and the ECO is extracorporeal carbon dioxide removal. So basically the function for the ECO is to remove carbon dioxide, especially in patients that are hypercapnic. So basically ECO is used for lung protection. And then for ECMO, we actually use it for cardiac and respiratory support. So you can actually use it in patients with cardiac failure, respiratory failure. And another thing that I discovered was that we also have the use of extracorporeal devices in cardiopulmonary resuscitation. And also in organ donors, you can actually use also this device to help in perfusion of the organs before you are able to remove the organ. So another thing also that I found out was that, so we have different types of ECMO, which I'm going to talk about. And there are nomenclatures that have been developed in the technology of ECMO, and also in ECO as well. So we have these nomenclatures where they use VA, VVA, VV. If I move to the next slide, the main idea of ECMO is that you place a cannula in the patient, and you connect the tubes and connect it to the device, to the circuit, which oxygenates and removes, it first removes the carbon dioxide and oxygenates the blood. You connect those tubes, and if you can see it from here, this is one of the cannulas that is being used. So we have the inflow, we have the outflow. The blood from the venous circulation goes into the inflow, and is being drained. So we call that the drainage cannula, okay, or the orifice, the drainage orifices. So it goes through the inflow, and you have that deoxygenated blood going into the circuit, and then there it is oxygenated, and also we have warm water being passed through to warm the blood. It doesn't actually, the water doesn't touch the blood, but it warms the blood. And then this is returned back into the patient. So oxygenated blood goes back into the patient, and it flows through the outflow orifice. We'll see more of this as I move ahead. So like I said, the nomenclatures that are being used, we have the veno-arterial ECMO. And when you look at the nomenclature, what it basically means is that you have the drainage cannula in the venous circulation. So the V, the first letter stands for the drainage one. So we have the drainage cannula in the venous circulation, or in the return cannula in the arterial circulation. Usually for neonates, the arterial circulation the site that is being used for the arterial circulation is the carotid artery. Or in kids that are less than 10 kilograms. For adults and kids that are above 10 kilograms, the femoral artery is usually used. Now, they have this other nomenclature where they talk about peripheral and central. And basically what the central actually means is that, so for ECMO cannula, you can place it by the bedside, transcutaneous, you can do it in the IR, but you can also do an open surgery in which you do median stenotomy. When you do that, that's for the patient. When you insert the cannula through median stenotomy, that is what is being referred to as the central VA ECMO. Now for the other one, we have the veno-venous. So like I said, that means the venous drainage is going to be in the venous. The drainage cannula is going to be in the venous circulation, and the return cannula is also going to be in the venous circulation. And the sites that are commonly used here is the internal jugular vein, usually the right, and the femoral artery. So I have this image which actually describes what I was talking about. So we have the VA. And if you can look at the nomenclature, the configuration here, so we have VFAF, which stands for the fact that the venous circulation is through the femoral vein, and the arteria is through the femoral artery. So we have venous drainage going into the pump and then into the membrane lung where it is oxygenated, and then oxygenated blood is returned back to the patient through the femoral artery. And another thing that I also discovered was that sometimes it can get complicated. So in this case, we have VVA. So it's a type of VA. But what happens is that you can sometimes have multiple return sites or cannula into the patient. So in this case, we have the venous drainage from the patient, which is the first V. And if you look at it, so we have like a Y cannula here, in which one end goes into the internal jugular, the common carotid, into the internal jugular vein, and also the second end goes into the femoral artery. So this is also a form of VA, but we have multiple sites. So sometimes you may have X-rays, abdominal X-rays, chest X-ray, in which you have all these multiple cannulas in the patient. And this one describes the VV, in which you have, so you can have it in the femoral, you can have it in the internal jugular vein. So femoral vein, and then into the internal jugular vein. Now, there's this cannula, which I came across here, in which you have what we call the bicaval ECMO cannula, in which what basically happens, okay, so there's a picture here. So what basically happens is that you have, I think I showed a kind of picture like this before. So you have the drainage from the SVC and the IVC, okay, and then you have the return into the right atrium. So the right atrium is the one that is receiving the oxygenated blood. In the past, normally you can have, this is, okay, so let me use this. So in the past, in some other circumstances, if you are using this single cannula, you will notice that you have the drainage from this IVC and you have the return from this SVC. There's possibility that the oxygenated blood, before entering into the right atrium, you can have some of it entering back into the IVC, and this is called recirculation. Now, what are the differences between VA and VV ECMO? The major difference, which I will say, is that the VA can actually be used for cardiac support. So apart from respiratory support, you can have cardiac support with VA. VV is basically for respiratory support, and the advantage also is that you spare the carotid artery. If you are sparing the artery, there will be no risk for arterial thrombotic complications. However, it has lower PO2 levels, normal myocardial perfusion, and normal pulmonary flow and perfusion. Why this is important is that if you think about the way the drainage, the return cannula returns the oxygenated blood to the patient. So you can know that if you are returning into the artery, you sort of like bypass the pulmonary blood flow. If you are bypassing the pulmonary blood flow, then there will be decreased pulmonary blood flow in VA. And also because you bypass the pulmonary blood flow, and usually for, like I said, for the arterial cannula is placed, you place it in the common carotid and it goes into the innominate artery. The coronary arteries actually come earlier on in the aorta, and therefore that means that you have lower myocardial oxygen delivery in VA, but you have higher PO2 because it goes directly into the artery. For the respiratory ECMO, so what are the indications by age group? For neonates, the commonest indication so far has been congenital diaphragmatic hernia. In the past, it used to be meconium aspiration syndrome, but because of the changes in obstetric practice, this has actually become second indication. And for pediatric cases, we see an adult, non-ARDS respiratory failure, they are top on the list for indication. And because viral pneumonia is actually commoner in adults, so viral pneumonia comes before bacterial pneumonia in pediatric patients, unlike in adults where you have bacterial pneumonia. Now I go to the role of imaging in management of ECMO devices. Imaging is important in placement of these devices. I'm going to show us a fluoroscopic, some fluoroscopic images that were taken during placement. And also we use it in determining the type and the position of ECMO cannula. So you want to know which type of cannula was used so that you can also be able to tell the proper location or positioning for this cannula. And then lastly, you look for complications. The modalities that can be used include digital radiograph, fluoroscopy, echocardiography, which can be used by the bedside, is cheap, there is no radiation involved. Also ultrasound. Transfontanel ultrasound has been of use in monitoring neonates that are placed on ECMO, because you will see later on one of the complications that can arise from ECMO management is hemorrhage. So these kids can actually have intracranial hemorrhage. So they normally try to check their transfontanel before and after placement. And they are also on anticoagulants, which can also predispose them to hemorrhage. We can also do chest ultrasound to check for complications if you think that the patient has pleural effusion, and also for neck ultrasound, especially during placement if you are using, or even for groin ultrasound if you are using ultrasound as a guide. CT is rarely used except in complicated cases. So what are the types of cannulas that are being used? We have the single lumen, we have the dual lumen. The single lumen, like I showed you, so you can place it in the femoral, and then you place the second one in the internal jugular vein. For the dual lumen, which I explained before, so this picture sort of like illustrates it well. But we have different types. So these ones are basically the single lumen. You can use them for the VA. And then we have different types for the dual lumen, okay, in which you have one as the drainage and the other one as the return. So this is the one I actually saw here during my rotation in pediatric radiology. But we have other ones, which I will also show us another type on chest X-ray. So I explained this recirculation phenomenon before, and you can see the oxygenated blood can get mixed again with the deoxygenated blood and reduces the efficiency of this. But if you have this, and that is why it's also important that this side hole for the dual lumen cannula, single cannula, faces directly the right atrium. So for the positioning for the VA, like I said, they use we use the common carotid artery. You expect the tip of that catheter to be in the innominate artery at the origin of the right common carotid artery, and the tip of the venous catheter in the right atrium at the level of the between the 8th and the 9th posterior rib level. For the dry lumen, because we have two types, so the bicaval is the one that has the side hole. You want the side hole at that level of the 8th to 9th posterior rib level, because that's where you expect it to be for the right atrium. And the tip is going to be in the IVC. So it's coming from internal jugular vein to the SVC, and then the tip in the IVC. We also have another dual cannula, the tip doesn't enter into the IVC, but you expect the tip to be at the level of the right atrium. So this is a sagittal view scan through the liver that shows us the IVC, and we can actually see the tip of this bicaval catheter in the IVC. So ultrasound can also be used to check for the tip in the IVC. Now this is two single lumen cannula. We have the arterial, which is in the common carotid, okay, and then we have the venous cannula. And like I said, you want the tip. So for this cannula, if you look at it, there is actually a lucent gap. So this is not actually the tip. You have to look for a radio-opaque marker that has been put at the tip. And this is expected to be at the level of the right atrium, which is the 8th to 9th posterior rib I talked earlier. What are the possible complications we can have from placement of the cannula, of the ECMO device? One, there can be malpositioning. I have some images I can show for that. Also, there is risk for distal hemorrhage or even hemorrhage at the adjacent to where the ECMO cannula was placed. So we can have hemorrhage in the pulmonary, in the adrenal, intraperitoneal, and like I said, also intracranial. There can also be thrombosis around the cannula, and I'll show us an image. Also, distal emboli and stroke, even in the neonates, is possible. Pleural effusion, right ventricular perforation. So like the bicaval cannula that we saw, the tip is meant to be in the IVC, but if it's not positioned properly and then you push in, it can actually perforate the right ventricle, and then hepatic infarction. Now, what actually got my, made me to be so interested was, I remember when I was with Dr. Gates, and normally when he sees a chest X-ray and he thinks, this thing is urgent, he picks the call and he calls the managing team. And then I was sitting beside him that day, and the chest X-ray I was looking at, the lungs were totally white. And I was waiting for him to pick the call, and he didn't pick the phone. And I was like, Dr. Gates, the lungs are totally white. And he said, oh, don't worry. It's normal for the lungs to be totally white out during ECMO device placement management. So actually that was that was the first time I was getting to know that. Now, when the lungs are totally white out like that, it's difficult for you to delineate the mediastinal structures. So, but the X-ray is not totally useless. One, you're looking at the position, and at the same time, you want to know if there is displacement of the lines, the tubes, okay, any tubes that have been placed, including the ECMO device. And if you look at this chest X-ray, you can notice that the cannula have been displaced. Those cannula have been displaced to the right. And even if you look at it, the NG tube also has been displaced. So that makes us to know that there's possibility of something in the left hemithorax that is displacing those cannula. And then you can now suggest that they should go ahead and do ultrasound, CT, so they can check if there is any fluid in there. I saw a publication where they reviewed the use of CT in patients that were placed on ECMO. And if you look at it, even over a period of 9 years, they had only 18 out of 429 patients that had or needed to do CT, chest CT. According to what I heard from Dr. Conrad, it's not as tedious as this, but in the publication, it was said that they actually needed like 5 personnel. For the patient safety, they needed like 5 personnel to be around the patient during the time the patient is being transported to CT suite. The indications for the CT in that publication, the highest was failure to progress. And the imaging findings they were found included consolidation, lung infarction, necrosis with cavitation, barotrauma, pleural effusion, pericardial effusion, hemothorax, pneumothorax, tracheal stenosis. And like you noticed in the previous slide, another indication that was also there was to define the anatomy. So sometimes they found vascular rings, even in the neonates. So it's an opportunity to define the anatomy in cases where anomalies are being suspected. And this neonate actually had hydropneumothorax on the left, had right necrotizing pneumonia. So first had a chest X-ray in which this was discovered, and then they did ultrasound. The hydropneumothorax was also confirmed in the right hemithorax, and the kid actually went on to have chest CT, which showed the necrotizing pneumonia and left hydropneumothorax. This is another kid that had adenovirus pneumonitis and eventually had barotrauma from during admission. This is a transfrontal ultrasound that shows intracranial hemorrhage. So we can actually see some hyperechogenicity, subdural in the brain, in the transfrontal ultrasound of this kid. All right, so now I'll move on to findings things I was able to get from here. Basically, I had like 6 cases, and I noticed that chest X-ray was actually the predominant radiological examination that was done. They had fewer ultrasound, fewer abdominal X-rays, fewer CTs. And this is chest X-ray of one of the patients who had this massive pneumothorax in the right and collapsed lung. Also had some pneumothorax, and also the opacity here, the lungs is collapsed. We can actually see the device. Okay, so this patient had single lumen cannula. We have in the IVC, we have in the internal jugular vein. It was, like I said, usually the right is used. It was initially placed here, but the patient pulled it out, so they had to replace it and put it in this other place. And that's the abdominal X-ray, which actually shows the cannula as it was placed through the femoral vein. The same patient had a follow-up CT, and we can actually see from the CT, we can actually see the total opacification densities that are filling the, completely filling the right hemithorax. If we look at it, so this is the cannula, the internal jugular, and the IVC, but you can see that there is pneumothorax and collapsed lung on the left, and the airway is totally opacified, totally filled. So there is no way this patient could actually have coped on his own without the ECMO device. This is a patient on dual lumen single cannula, and you can see the tip, as it goes into the high VC. Okay, the lungs are totally whitened out. The patient was initially was actually on endotracheal tube, but later the patient was placed on, it was removed and changed to tracheostomy tube. And this is an ultrasound through the liver that actually shows the tip of the cannula in the IVC. And here we can actually see the cannula again in the IVC. This is a sagittal scan, and Doppler has been applied there. There's something Dr. Gates always says when he sees, he's always looking for the Doppler interrogation, and actually saw a case presentation of a patient that had hepatic thrombosis from placement of ECMO cannula. And the Doppler, interrogating the ultrasound images with Doppler is actually essential. And like in this case also, I expected that so this is the hepatic vein, we can see from here. So this is the hepatic vein. It drains into the IVC and then it flows away from the transducer. So you expect it to be blue, but you can see that here it is red. And what we actually suspect, because I discussed this with Dr. Conrad, is that the cannula may have been too deep, such that you have the side O pumping directly into the hepatic vein. So it's also important not just color Doppler, but also to check the waveform. Initially, I thought this was a VA because we have the cannula in the femoral artery and also in the femoral vein. But this is actually an echo, okay, that was done here. And if this is actually going to be an ECMO cannula, the tip are expected to be in the high VC. So this is a type of echo in which short cannulae are being used. Another patient with single lumen cannula, and we can see the post-treatment chest X-ray that this is very effective in treating this patient. Nobody actually will believe that this patient had this kind of lung, seeing the post-treatment chest X-ray. This is a kid who also had a dual lumen also placed, and we can see the dual lumen cannula in the IVC a bit too deep, The kid also had some effusion, and picture catheter was inserted, was placed. We can see the chest CT that was done, that there was some lung consolidation, ongoing lung consolidation on the left. These are static images from fluoroscopy guided placement for a pediatric patient, and we can see the guide wire, okay, and the catheter was placed, was inserted, and actually we can see here the side hole, okay, this is the side hole, and like I said, it's expected at the level of the 8 to 9 ribs, just at the level of the right atrium, okay, and this was what Dr. Gates was talking about. So if you look at, so there is a step down from the diameter of this cannula as you move down. And you can actually see a tiny lucency in between the tubes, in between the two segments, which actually looked like there was some fracture of the cannula, but this is how originally it's supposed to be. And this is the same patient. So after the cannula was placed, there was migration of the cannula superiorly, and this is where the side hole is. So this is a bit high, and this was an attempt at replacement or repositioning the cannula. So it was moved down. Not really where it's supposed to be, it ought to be, but a bit better than what it was. All right, so the same patient, and this was the chest X-ray at after treatment. And this image actually makes me smile every time I look at it. The baby did well, the kid did well, and he was discharged. On a lighter note, I saw this because I could just imagine this kid walking away and feeling so proud. Yeah, my doctors did it. So I saw this, image, which made me to laugh as well. All right, so that is the end of my presentation. I would like to say a big thank you to the program chairman, Dr. D'Agostino, the program director, Dr. Simosini. Special thanks to my supervisors, Dr. Gates and Dr. Previgiliano, and Dr. Stephen Conrad. Thank you very much, sir. It was really supportive, and I have a book as a souvenir that I'm taking home. And hopefully I'll become an expert in ECMO. Thank you so much, sir. I also want to say thank you to all the faculties. Everyone has been so kind. I love the lectures. I love the teachings. It has been really, really, really fantastic. It has been a good experience for me. I want to say thank you to the residents too. I know everybody is stressed out, the work and all of that, but I love the smiles that you give me. I want to thank Miss Elizabeth Winkler also for her support, for helping me to coordinate this during the time I was applying. Met many medical students, PA students who became my friends. And finally, I would like to say thank you to Kendra, who was able to help me to extract the images, the data for the patient. Thank you so much, everyone. And this is thank you in my language, Eshe. This one, as in short E, Eshe. Thank you.
Dr. P and I are the ones that mainly see the ECMO, and Dr. Conrad, there was been two, wasn't there two? It looked like there was that break, and we said there's no reason for it to be a break, and then Dr. Conrad came down with the actual ECMO device, and he showed it to us and taught us, like that one that has the one that we always see all the time. The upper hole is the not the reinfusion, but it takes the blood. You want that in the superior vena cava. The reinfusion port is the middle one. You want that in the right atrium, and the lower one you want in the inferior vena cava. And he showed us that, and we really appreciate it.
I want to congratulate you.